afternoon. This is Dr. John Bennett broadcasting from Bharatnagar, Nepal. Today we have another webcast for the weekly ACNS Neurosurgical Student Society. And today we have the pleasure of having Abid Saleem, a neurosurgeon from Pakistan. He's going to talk about gamma knife, radiosurgery concept, techniques, and indications. And before we introduce the doc, turn over to the doc, let's go through the panel. Good day, Melenis.
Hi, my name is Melenis Fuentes. I just graduated with a master's and I'm applying to med school.
Where are you from, Melenis?
Miami.
Okay, Viva Miami. Okay, Gaurab, could you please introduce yourself?
Okay, hello everyone. This is Gaurav Bhatta from Nepal, and I'm studying in my fourth year in College of Medical Sciences in Nepal.
Okay, Gaurab is on a smartphone, a little technical problem there. Okay, good day, Nourlane. Nourlane, welcome back. Could you please introduce yourself?
Hi, I'm Nourlan. I'm from Karachi, Pakistan. I work at Liaquat National Hospital in the neurosurgery department here. Basically, we've associated the Pakistani Student Society that we founded like a couple of years ago, and we're working with John Bennett with it for students. We're basically making a platform for students to learn and get familiar with neurosurgery. So thank you for always inviting me and always having us around and getting us involved.
Great. Yeah, welcome to all the shows, Nourlane. Okay, Rakesh.
Hello, everyone. I'm Dr. Rakesh from India, Kolkata. I'm a neurosurgery resident, and I've been a part of neurosurgical TV since past few years. So I'm very glad to be a part of this team, and I'm looking forward for this lecture. Thank you, everyone.
Very good. Welcome back, Rakesh. And Slaven.
Hello, everyone. My name is Slaven. I'm from Croatia, and I'm the leader of the Dandy Neurosurgical Club here. I'm also co-administrator at Neurosurgical TV, working with Dr. Banner for a long time, and really lucky to see how this platform grows and all the world-class lectures that we can hear. So I'm really eager to hear about gamma knife today, and thank you for this.
Great. Welcome, Slaven. Okay, Abid, it's all yours. Thank you for coming.
All right. So we're going to talk about the gamma knife radiosurgery, the basic concept, the technique, how we do it, and indication, when it's indicated. Right? So this is a New England Journal Medicine article in 2012, which reveals the 200 years of cancer research. And it mentions in 1968 the birth of gamma knife radiosurgery. Can you hear me now? Right. So this is the definition by Lord Flactor in 1951 of radiosurgery. A single high dose of radiation, stereotactically directed to an intracranial region of interest, maybe from X-ray, gamma ray, protons, or heavy particles. But now there is a bit advanced definition. It says a high dose of ablative radiation delivered to a target but less dimension with overall end-to-end sustained on the order of 1 to 2 millimeters, delivered over 1 to 5 feet. Now we can deliver it in more than 1 feet. So this is the picture which will give you an idea what I'm talking about, the image-guided focus of energy radiation. And this is the result of radiation in the brain spectrum, and it's showing how precisely it occurs where the radiations are directed. So some words about the radiobiology. The radiosurgery allows the surgeon to operate at a macromolecular level with the cutting of nucleic acid strands for performing protein biosynthesis. These different steps in radiobiology, because in initial seconds, several hours, several years. So it causes ionization of atoms, it causes the DNA damage, which ultimately leads to the cell death. The molecular responses to radiosurgery, this is the DNA, the various signaling pathways, what's the endochemical effect. This actually is the whole topic which I want to discuss. So we'll do it from there. So where the application, the radiosurgery causes differential cellular effects. Yet it has wide applications to a variety of cerebral disorders. For example, it can make tumor cells stop dividing. It can cause abnormal blood vessels to occlude. Or it can make neurons with aberrant electrical activity to stop firing. Something about the history. This is uh, Dr. Lars Lexley, was a Swedish neurosurgeon who first coupled orthovoltaic X-ray tube with his stereotactic guiding device to focus radiation on the exterior ganglion to treat trigeminal neuralgia. This is the stereotactic device which we initially made to take biopsy samples from the different areas of the brain or the brain region. So what he actually was trying to do, that if he wants to take a biopsy from the ganglion to deep tissue, how he can do that. So he made this device in which he used this Cartesian coordinate system. It's all neurosurgical residents may be familiar with this idea. If you know the XYZ value of any place in the brain, you can use the device to target that. So this is the device which he was using. This is the initial frame which is placed over the head, and then utilize this unique circle of arc principle in which if you know the XYZ values and you place the coordinates on this, if you want to enter, if you target this lesion for anywhere during this in this circle, it will be able to reach the center of the circle where this XY coordinates guided you. So this by using this two-tactic device, we said that instead of putting a, uh, an instrument
Well, thank you.
to this area, we can actually guide the rays to that lesion to make an effect. So this was the whole idea. So he investigated initially the crossfire photon beams as well as X-rays from early generation linear accelerators for radiation for light. He finally selected cobalt 60 as an ideal photon radiation source and developed the gamma knife. So the clinical work really started in 1967 at the manufacturing site which was in Linköping, Sweden. First patient visit was at the clinic in Vienna. Then another hospital in Sweden installed it in 1975. In 1980, it reached Sheffield, England, and then the entire Argentina. And finally, in 1987, when it reached North America, actually, technology got a great boost. And it has been, uh, there are several hundred of centers all over the world. Actually, I wanted to show you the initial prototype machine so that we can actually able to see how the technology has developed from a simpler machine to a very technologically advanced machine. This is one of the initial machines. You can see this is the helmet which was initially used, and patient actually this is the cut section of the initial device. Patient lies there, head is inside this helmet. The couch goes in and attached to this inside helmet. Now here in the semi-spherical portion, the various cobalt sources, more than 200 sources, are placed, and they all uh, focus on the lesion according to the XYZ value. This is the perspective zooming in, and this is the pellets which are the source of radiation, and these are the collimators which guide the radiation to the. So we have different sizes of collimators, which are 4 millimeter, 8 millimeter, 14 and 18 millimeter collimators. And you can see the radiation that they produce in the target. This is the cobalt between. Uh, we have an automatic positioning system which actually guides the rays to the lesion. And this is the workflow. You can see here the patient with the frame on goes into the MRI. The MRI comes to the gamma plan. But after the plan, the plan goes to the operating console, and this is how it is delivered. Now, how we have is different from the conventional radiation therapy. And this graph is a very important graph. It shows the intensity of the radiation and the size of the lesion. Where the size of the lesion is large, the intensity is low, we use conventional radiation therapy. As the lesions become smaller and we want to increase the radiation dose, we go for either conformal radiation therapy, IMRT, the intensity modulated radiation therapy, and then to image guided radiotherapy, then the speed active radiotherapy, and there you see the dose is maximum and the lesion size is small. So, but you are able to deliver a very high dose to the lesion. There are two principles which we follow here: selectivity and conformity. Conformity means that how well the prescription isotope is fitted to the target, and selectivity means that the radiation to the normal tissue is minimum. This is the conformal. So our principle is the whole target and nothing but the target. So the mechanical accuracy is less than 0.3 millimeter. The radiological accuracy 0.15 average, and total accuracy is 0.48 millimeter. This is the procedure in our old machine. We slide the frame here and send the patient for imaging with this frame. The images come to our gamma plan computer where we plan, and then this plan is executed by this machine. We can actually also use the PET scan images and storage storage with the MRI of the CT for better delineation of the target. Okay, so this was all was the old prototype machine, but now what we have is this the icon machine. So we started with the prototype here. This is a much improved machine, another improved machine. This was the 4C model, which we were using in 2008. Then came this perfection model, now this icon. I will show you what is the difference. So this is the new icon machine which has been installed in our center last year. And what's new in this technology here? Before that, we were treating all our cases in single session. Now with this machine, we have the ability to do more than one session treatment. They have made it possible? They have introduced this cone beam CT right on the machine and an infrared detector system to monitor the patient movement. So this is a new workflow with the cone beam CT, which is truly stereotactic. This is just not the simple CT; it's actually a truly stereotactic CT. And we have the option of doing the treatment with the frame or with the mask. And then there is a constant real-time tracking of the patient position via stereoscopic infrared detector, which is called HDMM. So the new workflow is like this: you have the option. Either we can use the mask system, in which we do the MRI of the patient, we do the planning, and we just ask the patient to lie down on the machine, and we place the mask over his head. And then we do a cone beam CT, which is available on the machine, and then we plan and do the dose evaluation. And this is with the mask, no frame involved. Now, this is the old system is also available, in which we do a frame, apply the frame, do a usual MRI plan, and then execute, in which you may or may not use the CT. So this is the old system. You can do a single section treatment, and then we can use either a mask without any frame, with the option of doing more than one treatment. This is just a blueprint of the cone beam CT. So this is a very fantastic thing. The cone beam CT, once the patient lies down, it takes 200 images of the same patient and make a stereotactic picture to us. Each voxel has it can calculate its XYZ values according to electrical coordinate system, and then you can co-register with the MRI images like this. This is the convenient CT of the patient lying down on the cot, and this is the MRI scan already available in our computer, and you can see how accurately it matches with the MRI. So it can use the convenient CT to do a single fraction treatment, or we can do a multiple treatments with it. So this is the mask which is now available to be used in the MRI machine. This is the old system in which we are using the frame, but now we can also use the mask. And once the mask has been placed over the patient, which is actually an individualized mask, which takes the position once it's wetly applied over the head, and it takes the position, the mold of the patient's head and face. We have the constant infrared monitoring of the patient like this, and this is so good that it's so precise that if we can put a limit on how millimeter the patient is allowed to move, and if it reaches that limit, it may be 1 or 2 millimeter or 3 millimeter. We usually use the 1.5 millimeter, and once if it detects the patient has moved, it can automatically stop giving the rays. You can see the patient reaches this line, the rays should stop automatically to readjust. So this is the precision slide which shows how good the new infrared thing can work. It can detect any movement less than 0.15 millimeter in between dimensions. This is a cross section of the new machine. Yeah, I'm showing you the old machine, and now this new machine. You can see the more space available for the head and neck. And this is the new collimeter system, which this is the old machine which has a smaller diameter, now it's bigger diameter, so it's easier to do and treatments. And the actual beauty of this is the collimeters have now been made into various sectors, and each collimeter is an option of further decreasing the size of that collimeter. So there are 8 sectors, which each containing 24 sources, with 8 servo drives, and the size of collimeter is now 4, 8, and 16. So this is the full collimeter. If you want to use on this is actually your target, which is inside the center. You can use the whole collimeter, or you can block or decrease the size of one portion, so it changes shapes. So we have a lot of shapes available for you. Like you have this lesion which is of this shape. If you want to treat, and you have to make our targets like all inside this lesion. So now with this short technique, you can very easily make your target delineation. For this, because we have the large diameter of the machine, all eccentric lesions which are lying to the side of the skull, which were difficult to treat before, now can easily be treated. This is the position. You can see very low in the neck can also be treated with this machine. This is the treatment plan of a low lying lesion. So, and this also actually corrects if the patient moves, the machine corrects its collimeter direction. So if there is physical motion, even if there is a rotation of the lesion of the patient, it can adjust like this. So as compared to a linear accelerator, this is the comparison with the gamma knife. Linear accelerator also has a cone beam CPU attached on the couch, but here there is no on-board tracking to regular orthogonal electric. But here we have the monitoring going on 20 times a second. So with this machine now we can say that we have best of the two worlds. That if we have a very small lesion target, we can do it in a single dose with the frame. And if there is large targets, in which we can do a frameless hypofractionated treatment, which can go up to 5 fractions in a session. Right. So we have this is the activity which we have done since 2008 at our section. You can see the various treatments indication which we have done here. It includes like the functional lesions like trigeminal neuralgia, the glial tumors, the metastases, other benign tumors, the craniopharyngiomas, spinal region tumors, adenoma, meningiomas, cystic carcinomas, then AVMs and other vascular lesions like cavernous malformations. This is the number and this is the percentage of various indications we have taken. So now I will go indication by indication to see the results, how this treatment gets effective. So we can discuss the vestibular schwannomas first. Since 2008, 294 cases of vestibular schwannoma have been treated, and there were 463 males, 131 female patients. The patient age ranged from 24 to 71. The median was 42.8 years. 40 patients, 70% on partial or total vaccine of the tumor prior to examination. The size of the lesion ranged from 448 cubic millimeter, 28 cubic centimeter. The median was 12 cubic centimeter. This is the age distribution. The usual age is the main patients from 30 to 50 years of age. They came with hearing loss, nitrous, vertigo, balance movement, spatial dysfunction of the deficits. We actually use a 10 to 14 gray at 50% isodose line. So the median was the 12 gray. And we then do a 6-monthly follow with the MRI of this patient. So this loss of central enhancement was demonstrated in MR images in 86.5% of the patient at the latest MRI session. Disease stable tumor was demonstrated 96%. No facial nerve toxicity, which is very common in surgical cases, but in our case, no facial nerve toxicity was observed. Temporarily non-specific vestibulocochlear symptoms are reported in 13% of the patients. Imbalance improved in 60% of the patients. One patient had to undergo surgery because of disease in 60% of the patients. Two patients had to undergo treatment. Like this is the case with Gemini. This is at the time of treatment. The volume is 1.9 cc, 13 gray at 50% isolated line, which we gave, and this is what we get at 6 months post treatment. You can see the necrosis inside the tumor and shrinkage of the site, and this is what we get at 1 year. The further shrinkage of the lesion. Another case, this is a bit larger lesion. This at 6 months, very nice shrinkage, and this is what at 1 year further shrinkage can see. Another case which is bigger than that, which is 18 cubic centimeter, we gave him a bit smaller dose, 20 at 50%. Again at 6 months, central necrosis and further shrinkage at 1 year. This is another case, pre-gamma knife and post-gamma knife at 15 months. This is a cystic carcinoma with cystic and solid portion. You see at 1 year, very nice reduction. So this was the vestibular carcinomas. Now we go to the meningiomas. This is a 54-year-old male. This was the residual recurrent meningioma presented to us. This we treated, and you can see at 1 year, this is the post Gemini picture, and this is to how this has consistently reducing in size. Now we come to the cavernous sinus meningioma. This is cavernous sinus meningioma. They respond very well to radiosurgery. Others were very difficult to treat surgically, but you can see at 6 months how good a resolution BHC in such cases. This is another case, same location, the parasite location, possibly a dermis meningioma, and this you can see at 6 months, very nice resolution. This is the same patient with sagittal images. This is another patient, similarly at 6 month reduction. Another case, this is repeated with 16 gray. This is at 6 months, this is at 1 year, and this is at 2 years. The reduction is persistent. Another case at after 2 years, a very small residual lesion. This is original lesion and this is the small residual at 2 years. So we have treated about 61, 69 cases of meningioma. 72 were male, 97 female, average age 45. 31% had residual recurrent meningiomas. Majority of the patients had cell-based meningiomas. This is the various locations. The meningiomas were located more so in the skull-based areas. The median tumor volume was 13 cubic centimeters. The median tumor margin growth was 13 K. The patient was regularly followed up with MRI images. So about of the 169 patient, 181 lesions, the mean clinical and imaging follow-up was 22 months. Follow-up was available 151 patients. 73% decreased and 25% remain unstable, while 4 patients increased in size. Treatment-related complications in 4% of patient groups which became of palsy and symptomatic edema. Another lesion which we are treating with the gamma knife is craniopharyngioma, in which we are using the multimodality approach. They are histologically benign neuroepithelial tumors that arise from hypophyseal ductal spouts. And they consist of squamous epithelial lining, cystic cavities, solid components that contain calcium and keratin products of squamous cell activity. Entirely cystic or entirely solid types are seen, but most tumors have a mixture of two components. There are two types, the adenomatous and squamous capillaries. So the various treatment options available for us, either to do a surgery or we can send surgery at the tumor, surgery of the states, either to remove the tumor in a gross total manner or limited manner. And then for the residual, we can do radiation therapy, which may either be fractionated or in single fraction or in multiple fractions. This is a male 32-year-old patient with headache and then vision. Left frontal clearly was done in 2007 and they had a residual clinical tumor. This is the residual clinical tumor which presented like this to us, and we treated him with 12 gray at 50% isodose line. Target volume was 7.1, multiple life centers was used. This is the plan, and this is the follow-up in 1 year. It's a very nice resolution of craniopharyngioma with improvement in the vision. This is the same lesion. We had the gamma knife at 1 year and at 2 years. Okay, and this is another case of craniopharyngioma, which is a 33-month-old child with headache and vomiting. The lesion presenting to us. Margin dose which we used is 10.5 gray at 50%. Target volume of 3 cc, multiple isotonically were used, and this is what we get at 3 months, and this is what we get at 1 year. The surgical section of the same child at gamma knife at 3 years and at 1 year. Another child which was 7-year-old with headache vomiting in large cystic craniopharyngioma. So in this case, what we did was there was a huge cyst here, so we drained it endoscopically, and this is the residual cystic craniopharyngioma what remains, which we targeted with 12 gray. And you can see the post gamma knife CT scan where a small speck of calcification remains. The rest of all the cyst had gone. This is another case which was heavily calcified craniopharyngioma, and after the gamma knife treatment, only the calcified part remained, the other cystic portions are resolved. So in this study, the 35 patients were treated with 8. There were 26 males, 9 females, 17 children, 18 adults were solid in 7 patients, and 4 mixed in 24 patients. And the mean size was 12 cc. The suction dose which we used, the mean was 11.5. 11 patients had subtotal section for gamma knife. 2 patients had neuroendoscopic investigation of the large cystic component. 17 patients had associated with circulation had BBC. 5 patients who needed omega reservoir replacement and 2 patients had received conventional therapy. Mean follow-up period was 22 months. Lesion outcome was excellent in 10 cases, good in 18, clear in 4, and 4 in 6. Tumor control rate was 80%. Progression rate in 20%. No patient with normal tissue function well after surgery. Complete radiosurgical coverage was significantly favorable. So in this study, we conclude that significant tumor control can be achieved with radiosurgery statically combined with limited tumor resection, drainage, or need endoscopy, or reservoir placement. So it needs a multimodality treatment to be successful. Treatment with surgical deficits are rare. So I think the last we will discuss the arteriovenous malformation. As you can see, there are actually 2 theories that they are congenital or they are developmental. And the basic thing we have to target is the nidus. So we have the draining vein or feeding arteries. What we need to do is to cover the avium nidus with our focus radiation. So this is a female 25-year-old with multiple hemorrhage veins. The avium in the deep secret area, which we treated with 20J, and this at 8 months you can see the effect. That good obliteration is going on. Only few flow wise available, and then at 2 years you can see a very nice obliteration. Only some surgical radiation edema is. This is the male 15-year-old treated avium and this at 6 months. Very nice ongoing obliteration. Another male 12 years 20 day treated. Total obliteration of the avium. Another case, 18-year-old with volume of 5 cc, and this is after 13 months. Very nice obliteration. Now this is a female child, 8 years of age, presented a large avium which was very near to his motor cortex. We treated with a bit smaller dose, but we are able to achieve total obliteration at 1 year. This is same child has shown the various other parts, axial, sagittal, and coronal. You can see very nice resolution of the avium. This is another case with 7 cc volume, and you can see the total obliteration of images. This is another child with 11-year-old male child. He has a very large we treated with 18J of treatment, and this is at 6 months. Very nice resolution, ongoing, and this at 1 year at almost total obliteration of the lesion. The same patient with the surgical cut, you can see very nice resolution. This is what I want to show is that this is the draining vein, and this is after 1 year of the treatment. This is the draining vein, how it has gone to the normalization. There is a female with a large intravascular avium which we got total obliteration in 2.5 years. This is the same patient which has axial cuts with very nice obliteration. So this what you need to see here is that this was the case we treated with the radiation, and this after 6 months, a very large edema. So from 5% of cases we see post-radiation edema around the lesion. But it was asymptomatic, and we treated it only with small doses of steroids, and this is after 1 year. All this edema has been resolved, and patient is fine with total obliteration of the edema. So for the avian, the lessons were learned that the obliteration rate at 3 to 10 years varies between 65 to 98 years after a single procedure treatment. and repeat SRX is required in 10 to 35% of cases. Large AVM may require multiple procedures. Embolization before SRX may worsen the risk. Complications occur in 1 to 10% of the patients. Associated aneurysm require additional aneurysm. Hemorrhage rates decline after state exit, approaching 1% like to embolus after image confirmed. Hemorrhage risk during the latest interval after state is not increased. So what else is in the origin? Trigeminal treatment we are already doing. You can focus, like in this case, the temporal lobe lesions causing the epilepsy, which can respond, and patient's epilepsy can be brought under control. You can do the Parkinson's cases, in which the previous theory of making the lesion, like VIM for example, can be done with MNI. And their whole study patients have been treated with, and the studies are available on people are also trying to make similar obsessive compulsive disorder treatments, which is done by reenactment with this method also. So in last 3 decades, Knife Radiosurgery as dedicated neurosurgical instrument has changed the landscape within the field of neuroscience and neuro-oncology by providing a safe, accurate, and reliable treatment option that continues to be a fertile field of investigation and innovation. This is our team. We have neurosurgeon, radiation oncologists, PHs, radiotherapists, radiologists working with us. Thank you for your attention.
A lot of the material, I know a couple of people remarked to me that was great slides from What's Up. I heard from them. They said great slides. A neurosurgeon, Herman Stoltz from Venezuela, said it's a great presentation. And so let me open it up to the panel now to see if there's any questions. Rakesh, since you're the only neurosurgeon on the panel, would you like to go first?
Yeah. It was a very nice presentation, Dr. Saleem. And it's a bit new to where I practice, so we don't do much of gamma knife radiosurgery. And I just would like to know that how many have you performed by yourself, and how do you see the results of this gamma knife surgery?
Yeah, actually, all of the gamma knife surgeries are done by me personally. Up till now, we have done more than 2,600 cases.
Oh, that's really great.
Yeah, and I showed you on various indications what are the different success percentages of various options.
Doc. Go ahead, Rakesh.
Yeah, I just wanted to know how are the results like.
Yeah, I told you as in my slides, like we started with the acoustic schwannomas, meningiomas, pituitary the success rate reaches close to 90% of these.
Okay, that's great. Thank you very much. It was a very nice presentation.
Okay, I have a question. You're the only gamma knife center in Pakistan?
Yes, I think.
Wow. Now, how long has it been operational?
Yeah, we started in 2008, May 2008. Okay, so it's about going to be 10 years now in next May.
Okay, do you see every year an increase in the amount of cases you have?
Yes, from the initial start, we accurately progressed as the neurosurgeons know more about it. But here in Pakistan, because we don't have an insurance system, so we are not be able to do as much as they are needed to be done.
Right. Okay, do you find yourself doing a lot of teaching to other neurosurgeons about when to use gamma knife and why in some cases it is better?
Yeah, we usually do in our regional conferences. We have different societies with us. In their annual conferences, I go and present them to them. And then there are various neurosurgeons who, if they are personally interested, they talk to me, they send cases to me and discuss.
Mm-hmm. So you see
this your platform is a great opportunity actually, which is an easier and cheap way to reaching a large population.
Rakesh, are there many Gamma Knife centers in India? Do you know?
Yeah, there are around 10 centers, I suppose. I'm not sure. But yeah, it's not so common. It's not so common in India. And I'm very glad to be hearing from a person from the only center in Pakistan. It's very nice to be a part of this talk. Thank you so much, sir.
Yeah. So you see it increasing, continue to increase. Do you see it? Yeah, you see it continue. Oh, okay. And I guess in your residency in Pakistan, I guess most of the residents don't get much exposure to Gamma Knife, correct?
Yes, you're right. Because it's only in one part of the country available. So, but in my own place, like Khan University Hospital, the residents they once in a while they come for a few weeks to train with us and to see to get a on-hand experience with this technology. It's difficult to get people from other areas till now.
Okay, so students from Pakistan, they can rotate and do like a mini fellowship for 2 weeks to get exposed to Gamma Knife.
Yes, exactly.
Okay. Okay. Well, I know that as a student, I think it's good for them to hear about the treatment, because you hear about Gamma Knife everywhere, even though you may not know much about it. You hear about it, and you kind of wonder. I always wondered what it was and when do you use it, etc. So AVMs, meningiomas, and gliomas, those are the three big indications for Gamma Knife, correct?
Yeah, gliomas in a recurrent setting mainly, but other indications, as you have said, there are acoustic schwannomas, meningiomas, pituitary adenomas, craniopharyngiomas, some of the final region tumors, especially in the recurrent setting. It's very, very useful.
Which lesion do you find it most helpful of all the brain lesions? The craniopharyngioma, acoustic neuroma, which areas do you see it very, very useful? Is there one area?
If you go by the number, we have been very successful in treating acoustic schwannomas, pituitary adenomas, arteriovenous malformations, and some of the craniopharyngiomas, if they come in our limits, right? Then in the recurrent setting, the pituitary adenomas, the recurrent pituitary adenomas. And two things I want to repeat again if I am not presented in my presentation. One is that previously it was thought that the radiation is for malignant lesions only. But as you see here, most of my cases are benign. So this is a great shift from treating only malignant lesions by radiation to treating benign lesions. These acoustic schwannomas, most meningiomas, benign lesions. They're benign lesions. But because we have been able to increase the radiation dose to these lesions by this technology, and limiting it to the lesions and saving the rest of the brain, we were able to give a high dose to this lesion. So even the benign lesions started to respond to radiation therapy. That is the real success of this technology, that we can even treat the benign, like a acoustic schwannoma. Is a benign lesion, but if it is a big size and you do surgery for that and you try to remove the whole lesion, the mortality and morbidity was very high. But now with this technology, the patient comes to us in the morning, gets treatment, and can go home in the evening, and from the next few days he can start on to his job again. It made it so simple to treat these deep-seated lesions with technology, especially in this scenario. This is the real. Other thing is I've not mentioned about the metastasis. Previously, it was thought that if the metastasis has gone to the brain, the patient will die of the brain medicine. But now with this technology, the metastasis of the brain, they respond within weeks and months. They totally resolve with this treatment. Though now we can say the patient a patient will not die of the brain mets, it will die of a primary lesion if reached to us within a proper time. So this is the great paradigm shift which in treatment of the cancer patients we see here.
Excuse me, I have a question. It's interesting when you mentioned about metastasis. I would like to know how long you can profile, how long you can prolong the life of a patient in metastasis, which already metastasized to the brain. So how long can you prolong it with gamma knife?
Yes, now it depends on the survival. Will now depend on the primary, in what stage the primary cancer is. For example, if a patient comes to us with around 1, 2, 3 metastases of the brain, they come to us for a single day, we treat him, and within about 3 months, he come back to the MRI, his brain lesions will be gone. Right now, it depends on the primary cancer, what stage it is for his prognosis. For a standard lesion, for example, if it was 6 to 8 months survival for these patients. It will not have to go through the whole month of radiation dedicated to the metastatic treatment. It will be only a single day. So, and so even if the survival remains the same, it's a great quality of life which we have added to these patients. But we are seeing a longer survival as the primary treatment is also getting better. We are seeing more and more survival in these patients.
Okay, thank you.
Okay, very, very good, Doc. You know, we can't end a presentation without entertaining a question from a guy they call the Croatian wonderkind, Slaven. Slaven?
Yeah, I'm here.
Let's go.
Thank you. Well,
come on, Slaven.
Actually, for me, this presentation was so academic and on point that it would be really a mistake to ask any questions. I think it was very clear. And I think that it was really a pleasure to have such a nice, because I always ask questions when I have some doubts. I didn't understand the concept, but here I really think it's really such an experience. Show that you're just stunned in a way and you don't need to ask any questions. So I would like to hear more. Love to hear more, and I would also love to. How can I say? I think this is a very important addition to the lectures we had opportunities to hear. We didn't hear much about gamma knife, so thank you for sharing this with us, and it's really been a remarkable experience. Thank you.
Yeah. You know, I echo what he says, Doc, because it sounds like the neurosurgical community needs to be educated about this technology. It's something, and the technology we're using now is a very useful tool for that, because you don't have to travel to a convention. You can do it from your computer. And hopefully our community will grow and we'll have a wider audience that you can reach for people who don't know much about gamma knife, for neurosurgical residents and neurosurgeons in other parts of the world that want to know about it and that are curious about it. So we thank you, and we invite you to come back for more, and we'll be in touch.
Thank you, John. It was a nice experience. Thank you for the participants.
Yeah, I'm going to send it to you. It's going to be all recorded. And thank you for all the panelists for coming.